Hi everyone, I'm doing my pediatric case presentation on a boy that I saw at the orthopedic clinic where I was for this semester for my pediatric rotation. So we saw a 2-year-old African American male who was brought in by his mother for bowing of the legs for the past 4 months. So the mother reported that he had been born vaginally with no complications at 40 weeks. She breastfed him for a year with no dietary supplementation, and she's denied any pain with walking or abnormalities with his walking. She states that he started walking at 7 months, and lately he's been a picky eater, only eating pancakes, and she can only get him to drink about 1 glass of milk a day. She denies any past medical history, any recurrent fractures. He's not taking any medications or dietary supplements, and he doesn't have any known allergies. On physical exam, all of his vitals were normal. He was well developed, well nourished, sitting on mom's lap with no acute distress. His lungs were clear bilaterally to auscultation, CV-wise, regular rate rhythm, S1, S2 observed. From a musculoskeletal standpoint, he had very obvious bowing of the legs bilaterally, but he did have 5 out of 5 strength in all extremities bilaterally, good range of motion in all of his joints, that he was negative for Jovex sign and Trousseau sign, and he didn't have any kyphosis or scoliosis noted on his spine, and there was no tenderness on any of the joints to palpation. His skin was intact. There were no lesions, alopecia, or cafe au lait spots. We were looking out for alopecia or cafe au lait spots because those can be signs of hypophosphatemia. So we ordered an x-ray of his legs bilaterally. We got labs of his vitamin D, alkaline phosphatase, serum, GFR, and creatinine. His vitamin D was very low. His alkaline phosphatase was a little bit elevated. Serum calcium was on the low end, and then his GFR and creatinine were normal for his age. And here is just an x-ray of a child with bowing of the legs, and this isn't our patient's x-ray. But you can also see that there's some, my preceptor described it, some ghosting of the bone on the bottom where it's just a little bit too pale. It should be more white, as you can see at the top of his femur. So our differential diagnoses were CKD, Blount disease, osteogenesis imperfecta, and rickets. For chronic kidney disease, there should be an abnormality of the kidney structure itself or with function of the kidney. Our patient's labs were normal, and mother hadn't been reporting any difficulties with urination or family history with chronic kidney disease, so this seemed more unlikely. And the way that you could get bowing of the legs with chronic kidney disease is there is some metabolic acidosis with chronic kidney disease. So it causes bone demineralization, and then this releases the calcium and phosphorus from the bones and then causes the bones to weaken, and they can start to bow at that point. But like I said, we ruled this out due to the labs and family history. With Blount disease, that's caused from pressure put on the tip of the tibia, and this causes the medial aspect of the tibia to grow faster than the more lateral part. So on the left, you can see that the fibula is even a lot more underdeveloped than the tibia, which is sort of taking over. So on the right, you can see the surgically corrected child. He has the staples or pins placed. That causes the tibia to be arrested temporarily and allows the more lateral aspect to grow and catch up, as well as the fibula. And then around 4 or 5, the pins can be taken out so that the bones can grow together at the same rate. We ruled this out because the only known etiology is obesity, and our child didn't have that. and there would be normal lab values with Blount disease, but our patient's labs were abnormal, so we ruled this out for our patient. Then the next thing that was possible for our child was osteogenesis imperfecta. This is a genetic disorder. It can cause elasticity of the joints as well as brittle bones. And one of the classic signs is blue sclera, which is the photo that's attached there at the bottom. But we ruled this out because you typically diagnose this, and we saw this a bunch at the orthopedic clinic where I was. But children come in after having multiple fractures that can't really be explained. And because our patient didn't have any history of fractures or recurrent fractures, we ruled this out as well as other risk factors like poor dentin and a few other things that you see with osteogenesis imperfecta. It seemed more unlikely. Last thing is rickets, and we ended up diagnosing the patient with rickets, which is caused by vitamin D deficiency. Some risk factors would be decreased sun exposure, which a lot of patients have in this DC area, decreased vitamin intake, which we know he had because mom didn't do any supplementation. He was breastfed for a year, which is another risk factor. And then he also had dark pigmented skin. So because of this poor vitamin D, little sun exposure, and then the lab values and x-ray were confirmatory. So you typically see a low to normal serum calcium with rickets, and our patient's was on the low end. And then serum alkaline phosphorus is elevated, which we saw with our patient as well. And then from x-ray, you can also see that there was bowing of the legs, and that's further confirmation of rickets. So to prevent rickets, the recommendation is that breastfed infants get about 400 international units of vitamin D a day, which our patient did not get. And then they should be having 1,000 mLs of either formula or fortified milk to ensure that they are getting the correct amount of vitamin D. So to correct our patient, we sent him with a script of vitamin D to get 500,000 units of vitamin D weekly. And then we wanted him to come back in 2 months so we could recheck his labs, get another x-ray, and then we educated mom on safety precautions because these children are very high risk for getting multiple fractures, so just playing safe and how to make sure that the house is safe for the child. We also encouraged more calcium in milk, and we gave her, there's this packet that was available for all the parents that shows all the food sources that you can get the proper amount of calcium. So 3 to 4 servings a day instead of just the 1 glass of milk. In terms of reflective practice, one thing we should have done is a x-ray of the spine. Children with rickets are very high risk for having spinal compression fractures, and while there was no kyphosis or scoliosis observed and he wasn't complaining of any pain, it still is possible that he could have had a compression fracture on his back. The other thing we should have checked for is parathyroid level, just to make sure that there was no involvement with any other hormones. But because of the clear dietary risk and other risk factors, we didn't think that this was very likely, but it still would have been a good idea to rule that out as well. And here are my references.